All right, here we go. So just one moment, Donna.
Okay.
All right, you're good to go.
Okay. All right. Good evening, everyone. My name is Donna Gunkel, and I am the Director of Clinical Integration at United Medical. And welcome to our United Medical ACO Diabetes Program Wednesday Wellness Webinar. This is our third one for this year in 2020. We began these last year as another way to reach out to our patients in order to provide them additional education regarding diabetes and all of the different aspects around nutrition and the different systems that are affected by diabetes. So we have had a host of specialists join us. We do this twice per month. So we hold these the second and fourth Wednesday of every month. I wanted to introduce our wellness program team. So Kamal Erkin is our chairman and CEO of United Medical ACO. Again, myself, Donna Gunkel. Dr. Rapu Hundal is our program director for our diabetes program. He's one of the endocrinologists in our network. We also have Tim McHugh, who is a physical therapist within our network. He helps educate our patients on exercise and fitness and how that fits into their program with regards to nutrition and diabetes. And we also have Jacqueline Tomasetti, who is our licensed clinical social worker, and our certified diabetes educator, Amy Wilcoxon, is also one of the 3 dietitians that we have on staff. We also have Fran Taccone, who is here with us tonight, and Beth Wright. So I'm going to go ahead and turn it over to Amy now, and she's going to talk a little bit about what we do with regards to our Wednesday webinar program.
All right, thank you, Donna. So my name is Amy Wilcoxon. I'm a registered dietitian and diabetes educator. As Donna said, since the pandemic, we had to stop holding our group classes. So we wanted to continue our education about how diabetes affects the whole body and all the different systems. So as Donna said, we're holding these webinars, which are available on our YouTube channel, if that's where you're watching now. So we talk about all different things that diabetes affects. We started these last July or August, I believe.
It was August, yeah.
In August. And as Donna said, this is our third one of 2021. So you can go back and watch the other ones. We talk about the heart and the kidneys and the feet and the eyes and exercise and a lot about nutrition and social work, mental health. So all different topics that we'll continue to talk about. And then tonight, we are thankful, we're going to change a little bit. We're thankful to have Dr. Peters, who is a bariatric surgeon, here to talk to us tonight about diabetes after bariatric surgery. I'm sure you'll address Dr. Peters that sometimes people think it's a magic wand. So I know you both are going to talk about that. And then we also have Fran Taccone, who's a registered dietitian nutritionist, who also sees our, I don't see very many of them, Fran sees a lot of them, our bariatric patients with diabetes. So we will turn it over to Dr. Peters if you're ready to start the first part of the presentation.
I think so. Good evening, everybody, and thanks for coming out at this late hour to participate. It's greatly appreciated. With respect to diabetes after bariatric surgery, I think we need to kind of lay the groundwork for where diabetes is before bariatric surgery, so we can develop a full appreciation for that. And if you take a look at this map, and this is pulled right off some of the CDC data, so if your data is different than my data, we can blame the government for that. But with respect to obesity and diabetes in the United States, and I don't want to just read off this, but it's about 42% of the nation that suffers from severe obesity. That's about 10% of the annual medical cost for the nation. So 1 dime out of every dollar goes toward obesity. And if there is an obese individual in the house or a family of obese individuals, you can count on extra costs to your household in excess of $1,400 per year. And that really, that grows rapidly. That money should be put away for savings, retirement, college funds, other things. Now, with respect to diabetes, you've got something that affects over 8% of the population as compared to obesity. And it breaks it down there by age group. And you can see that really it's a disease of the elderly. When you look at over a quarter of the population over age 65 is suffering from diabetes. Now, of those with type 2 diabetes, 80% are obese, and that's usually where I get consulted to come in and take care of these folks. But 85% of diabetics are generally overweight. I think that's how impaired glucose tolerance starts. And it's amazing to look at the numbers with respect to cost here, because your direct medical cost of diabetes to a household relative to obesity can get you to close to $10,000 per year when you look at lost wages at work, medications, and some of the comorbid conditions that come from diabetes. So that's about $10,000 a year that families don't get to benefit from. You can go to the next slide. So diabetes after bariatric surgery, and that's really what we need to look at here. And we need to appreciate medical management and behavioral management before we opt for surgery, because those are the cornerstones of therapy. And we have to understand that the medical management of diabetes is just, it's certainly not perfect. It's understood that diabetes is progressive. And even with medical management, worsening of that diabetes is assumed. And I don't think that's emphasized to patients enough, or there'd be greater effort on their part to avoid the comorbid conditions that result. So we have to tell patients that medication will not reverse this disease. It will be progressive and worsen. And it usually comes to the attention of the physician somewhere between 2 and 3 years after they've had the disease. So they're walking around with this, and it may come to light that they have a pounding headache one day, or they can't see straight, and they go to the emergency room and their sugar is 380. And that didn't happen in 24 hours. That's not the result of eating an ice cream sundae that day. That's been going on for years. And during this time, there may be weight gain that's occurring as well. And surprisingly, it is behavioral management that is the cornerstone of good therapy. Because when you take a look at the volume of patients who are overweight and have obesity, not all of them qualify for surgery, fortunately, but they all do qualify for some sort of diet and physical activity and intellectual therapy. So behavioral management has the statistically largest effect. You can have a patient, and if you break down the statistic and take it back to your patients in the office, if they would lose 20 pounds and keep it off, they can drop their hemoglobin A1C by over 2 points. And that's going to get them back into control with diet alone. And if you impress upon them the dollar figures for diabetes, the comorbid conditions that result from diabetes, and all it is dropping 20 pounds by knocking out the appetizers and the desserts and getting the sugar out of the coffee and stopping the mocha latte double frappuccino half calf, then I think that really speaks to some patients, and I think you'll have greater success with promoting diet control in the patients, so they never get to see me. So for the average patient, each kilogram of weight loss in this research was associated with 3 to 4 months of prolonged survival as a patient. I think that's a huge statistic for those patients who can understand that sort of information. So really the best strategy for the bulk of these patients, because there's so many of them, is to inundate them with the positive effects of weight loss, physical activity, and nutritional control and modification, because that's where we get the biggest bang for our buck as providers and as a nation that's in significant healthcare debt. Can we go to the next one? Okay, so the meat of the argument here. So diabetes after bariatric surgery. We can talk about patients who have had surgery. They have acute postoperative care needs. The hospitalized patients have medical or endocrine consults placed based on their preoperative severity. So those individuals on insulin who undergo surgery, the change in the glucose level doesn't change with weight, it changes with the operation. That glucose level will drop dramatically in 24 hours, and the patients need to start adjusting their medications, and the nursing staff is aware to titrate the insulin drips and whatnot. Outpatients, and this is where some doctors they're amazed. Patients go home the same day now from these major operations, which used to be 2 days, 7 days in the hospital with prolonged recovery. We now have them done. These operations are done in 1 hour to 90 minutes, small incisions, and patients are out the door in 6 to 8 hours. And they're off their medications, and they're going back to their family doctors in 10 to 14 days, getting their medications, not just diabetic medications, but blood pressure medications adjusted. But we have to beware because insurance companies are now denying surgery for hemoglobin A1C over 7, and we have to start running even tighter diabetic control preoperatively, which is honestly why we got referred the patient in the first place. So it's kind of counterintuitive. But in the surgical literature, I need practitioners to be aware that these patients have to have much better control than double digits to get an operative intervention, whether it's a hernia, whether it's bariatric surgery, because the infectious complications go way up, the blood pressure complications, stroke, blood clot, all increase as the hemoglobin A1C increases. So practitioners should be aware that we have these resources as outpatients, as inpatients, and we're going to rely on you preoperatively to really kind of tighten up these patients a little bit before we get them onto the operating room table. We can go to the next slide. And if you want to know how we manage these patients, everybody, 10, 15 years ago was talking about the gastric bypass. There's been significant changes in the world with respect to bariatric surgery, but in general, they're divided into two types. The restrictive type, where basically you eat less because there's been a restriction placed on the stomach. And that's where you talk about your gastric band patients, your gastric sleeve patients, which are rely more on restriction of volume of eating. And you can see remission of diabetes in the area of 45 to 60% of these patients. And after sleeve gastrectomy, you'll get higher than 60%. And some studies, based on how long they do their follow-up, how aggressive their sleeves are, you can make them very small. You can make them a little wider. Based on that literature, you might see results that are even similar to the gastric bypass operation. That leads us into our malabsorptive operations, which don't just operate on restriction, but incorporate some degree of nutrient deficiency causation by malabsorption, and bypassing areas of the duodenum and causing bile salt reabsorption rates that are different than what you have in the virgin abdomen. So studies with more than 10 years of data on these malabsorptive operations sometimes quote an 80% remission of diabetes for gastric bypass, with a 95% remission for the bigger operation, the duodenal switch. But I'm gonna throw myself under the bus a little bit. That data is skewed. It's surgical data, and when you look at this stuff long term, those numbers are not as high. They're much higher than any medical management, and unfortunately, they're higher than behavioral management, which I really think we all need to emphasize more. So this is really shorter term data that's most often published, and sometimes the stuff is even 1 to 3 years. And most of my patients will follow up with me for 1 year at the drop of a hat. They're very happy, but trying to get somebody to come back and talk to me after 3 to 5 years is challenging. There's been weight regain. There's been some medications have changed, and oftentimes they're not as happy to see me, or they're ashamed, they say, to come back and talk about it. So just beware. The numbers look great when you're reading through the abstracts, but when you drill down on the actual paper, the numbers get a little fuzzy. We can go to the next slide. So what's the reality here? What do you say to your patient? Well, yeah, the short-term outcomes are that, you know, over 50% of the patients will have remission at 1 year, complete remission, and over 75% will improve dramatically with reductions in all their other medications. So these patients come to see you 6, 8, 9 months later. They're glowing, they're smiling, they've changed, they're in new clothes, they've gotten rid of half their medications. That $9,000 a year debt is now down to, you know, $1,500 a year because they're just overweight now, and they're really happy. So you need to evaluate whether your patient has severe diabetes before you send them to us, or is suffering from diabesity, which is more like impaired glucose tolerance. And you have to look at all the options there, from nutrition to surgical management. Let's go to the next slide. So what do you say to your patient? Let's look at the long-term outcomes. So, and I put that in quotation marks. At 1 year, about 10% of your sleeve patients will relapse with respect to their diabetes. And at a bypass, about 8%. All right. So that's not zero. That's not an amazing cure. The word cure should never be thrown around. I say remission to all my patients. And then if you take a look at the long-term data, and, you know, if you've been around 55 years now, 5 years is not long, but sleeve relapse is somewhere in the area of 40%, and fully a third of bypass patients will relapse to diabetic numbers. Now, their hemoglobin A1C will probably not go back to 11 or 12, but they'll get in the 7s and 8s again, and they'll need medical management. And they certainly need more nutritional management, because weight regain is always part of this, although skinny bypass patients have had their diabetes come back too. It is a metabolic disease. Let's go to the next patient. So there are patients where the big gun, or the duodenal switch, which is, it's an operation that I do and Dr. Wynn does, it's substantially more effective. If you have a patient and they're just all over the place with their weight and with their diabetes, it is a superior operation with long-term outcomes at 10 years of about 68% effectiveness. And I have talked to patients who have familial hypertriglyceridemia, early coronary death, and I've told them, you know, a band, a sleeve is not the way to go here. You'll get better for 2 to 3 years, and then you'll have to come back and see me. I tell them this is the way to go, because this is the most, the operation that'll do the most metabolic rearrangement, and has the best opportunity to cure that. And luckily, we can take a sleeve and convert it to a duodenal switch. So for a lot of patients where diabetes has come back, and maybe it's worse, maybe it's not, and their fear is diabetes, we have this in our quiver as a backup to offer them. But the quotes here are that, you know, 75% for Roux-en-Y gastric bypass is a resolution rate at 1 to 3 years. That's a number you want to be able to quote to your patient. I think that's a fair assessment and the broadest applicable in the literature. Do I have another one? Yeah. So the factors that predict total remission, and this is for diet, this is for the nutritional intervention, this is for behavioral management with the exercise therapist. You have a much greater chance of long-term remission, or cure, if you will, for patients who have had their diabetes over a shorter term. Somebody who's had it for 8 to 10 years, they have a higher chance of relapse. Somebody who's got double-digit hemoglobin A1C and they're on 2, 3 medications and insulin, they have a higher chance of relapse. It's ingrained into their metabolism at this point. We can get them to no meds, but we have to counsel them that their recurrence rate is probably a third at 10 years easily. Younger patients, all right, and so we have to strike while the iron is hot. These folks have to come in, and if they have a hemoglobin A1C of 6 and they're, you know, 29 years old and they're overweight, you have to lay out that data that I talked to you about with the finances, the comorbid conditions, what it does to the healthcare cost for their family, for the nation, and show them that it's totally reversible with a 20-pound weight loss. And in my world, 20 pounds is nothing, you know, although I haven't been able to do it myself, but it's significant. The better pre-op control you can get, the absence of insulin. If people get under tight control quickly, high likelihood of remission. If they come to me off insulin, high likelihood of remission. Their triglyceride levels are normal, or they have the good, fluffier triglycerides, if you will, higher likelihood of remission. Guys have it easier than girls. They always do with respect to diet and diabetes. And then their degree of obesity. Obviously, if they're very large, body mass index of 50 or higher, the remission rates are lower. And I think that's common sense. So if you can see a patient who fits this profile and you can intervene earlier with diet, physical activity, endocrine counseling for these folks, I think they'll all do much better. And if they do have surgery, these are the types of folks who will not get their diabetes to come back. Do I have another slide?
I think that was the last one.
Okay. I wanted to bring up something before we move on. I saw in the news tonight the diabetic medication that we know causes some weight loss in our patients anecdotally, semaglutide. I know Ripu probably gives this out frequently, but they are applying for FDA approval as a weight loss medication. You may want to buy stock, because if it goes, it's going to go fast. But now there's another medication in our armamentarium possibly that we could promote for weight loss at the medical level before they ever get to a surgeon.
That's great, because now we have Saxenda, which is Victoza, which is really great for people who can't take Belviq and phentermine, and it's expensive, but it really works. And it doesn't do, like, we don't have to worry about their blood pressure. They just get really full. And the ones I see on it who insurance covers it, it's really good. So I'm really glad to hear about Trulicity. Oh, that's good news.
Yeah, average weight loss in their study was 30 pounds. I mean, that there fixes the problem. I talked about 20 pounds, that's 30. So I'm excited to use this as an option.
That is great. Oh, that's great news. That's a good drug too. I like it.
And I may have missed that, but Dr. Peters, over what time frame was that 30 pounds? I mean, like, how quickly were they losing 30 pounds?
I'm not going to fudge an answer. I don't know.
I was just curious if it was something that was happening in, 6 months, a year, like how that was. And I do have one more question for you before we move into Fran's portion.
Sure.
So when we talk about, the changes after 1 year, do you think a lot of that does have to do with patients kind of resorting back to some of their prior eating habits? Or are there other other causes there?
There are typically three factors. The honeymoon's over, and then there's the three factors. And one is food, one is fitness, and one is often, I hate to say it, medications. At least that's what I see in my practice. Yes, people do slide into poor diet choices again. They don't typically live in a bubble. They live in a family, and there's other things in that refrigerator or that pantry that sneak in there. So there's the food issue. There's fitness. I think now that we're all strapped into our Zoom chairs, our steps per day are all down. And so our overall level of fitness is worsening. And it's true for patients as well. And then I see a lot of patients who have an issue. A lot of it centers, unfortunately, for ladies around birth control. I think a Depo shot or a Norplant or the wrong birth control pill can put 30 to 50 pounds on a patient in 6 months. It is essentially irreversible, even with weight loss surgery, unless it's your first operation. Steroids, are another issue. I see tremendous weight gain with steroids. It is essentially irreversible unless you have a first operation and never use steroids again. Some people are more susceptible to it than others. The final one is psychotropic medications, your Lexapros, your Prozacs, your all of these things. I think there may be an over-reliance my father is an internist, retired, but I think there might be an over-reliance in the primary care world to write a script, give a medication, move them out the door. And you know what? It's okay to be mood altered sometimes. And you know, people have to process that. But those three things seem to be leading indicators of weight regain. And sometimes it's beyond the patient's control, and it's very sad.
I appreciate that. I just think that's important for the people that are watching this or will watch this on our YouTube channel. So we'll go ahead now and move into managing diabetes after bariatric surgery, guidance from a registered dietitian, nutritionist perspective. So Fran, if you would like to, I'm going to go ahead and move to your first slide. You can introduce yourself and go ahead and lead into your presentation.
That's fine. It's good to be here this evening. If you're watching live, I could have also renamed this diabetes management before, during, and after bariatric surgery, because it's really a continuation, I hope, of the healthcare process to have the healthcare team. I happen to be one of the providers on the healthcare team. And Dr. Peters, it's great to work with you and the rest of the surgeons as we help these patients through. Not knowing who our audience is tonight, I kind of thought that we were talking to potential patients of bariatric surgery, or those that have already had bariatric surgery, or people that are just curious about the topic. But I wanted to be clear about what I was learning about these terms, remission versus cured. And I agree that the word cured is pretty strong, and we better use that very carefully. I'm finding the term prolonged remission might be helpful as well. But these are the way they're defined by the American Diabetes Association when I looked. And just noting that we still need to check the A1C, and so people shouldn't be off the healthcare grid. They still should be going in and getting their A1C test. Of course, it can be run every 3 months, but sometimes they just, as you say, wander off, and we don't always know how this is going. But the limits would be if they have their A1C down below 6.5, and that continues without the medication for 12 months, we call that partial remission. Full remission, then less than 6.0. And then if they do manage to continue up to 5 years, some people call that cured, but I prefer the prolonged remission as well. All right, let me just move on here with the slides. You also had a nice list, Dr. Peters, of the other factors that predict this remission and the burden of diabetes returning. My list is similar, and you know, it is certainly age related, and the A1C. Just having diabetes for a shorter term, of course, you know, how long do we wait? You know, how young do we intervene with patients with something like surgery? You know, that is a question. I'm not sure we have the answers yet, but I notice patients could be getting younger and younger, and maybe for good reason if things get really out of control. Having, of course, a lower A1C, and then having more insulin production, the pancreas in better shape. That's all just really saying that things are in better condition. There's more likelihood of things going well if those are in good order. But it's always about, as you mentioned, greater weight loss. And more specifically, I like the term body fat loss, because that's the tissue that's insulin, really insulin sensitive. So let's just talk about the causes of remission like you did. And in bariatric medical nutrition therapy, of course, we strive to help you achieve the weight loss, as I said, before and after surgery. So what we're doing is, these are the things that would help with targeting remission, having the healthy weight. And we want to, of course, address any imbalances of the calories. So we do work a lot on helping patients practice calorie and carb control, because that, of course, is going to make a difference all along. So when we find out what's in our food, it doesn't matter when it happens, but when we find out, well, what have I really been eating and drinking, and how that affects my body, particularly glucose if I have diabetes, and how much, how often, and then of course how we use the glucose as our fuel for that healthy lifestyle. I think that's really important. So we want to address these needs along the lifespan, with or without surgery, and with or without diabetes, but especially when the two are combined. At the cellular level, because of the bariatric surgery, I learned that there are specific hormones that are affected here. And I'm not the endocrinologist to talk about this in any way, but the GLP-1 hormone is affected, and that does slow the gastric emptying and suppress the appetite. And that of course, can help stimulate insulin at the same time. And then having less of the ghrelin hormone could also help or cause remission. So other factors we don't even understand are also at play here. So as you said, there's a lot of research to be done, and how long we do these studies, people don't follow up. It's hard to do nutrition research with those humans. They wander about and they do random things, and people get very frustrated with us when things change often. Oh, you told us this 10 years ago, now you're telling us something else. So that's the reality of what we do. That's why they call it the practice, right? The practice of medicine, or whatever our scope is. One thing we do find as a part of what happens after bariatric surgery is this problem of dumping. Dumping syndrome, of course, can happen even without bariatric surgery. And so these are the symptoms, and you know it when you see it, basically, or patients, they feel it, of course, and it's like, oh, I'll never do that again. What was that? And so we want to warn them about it, and just know that it can happen. And it's really quite a concern if we don't get a handle on it soon. I had noted here that 20 to 50% of patients have some form of dumping syndrome after their gastric surgery. And then, like I said, once they figure out what the triggers are, they tend to do a better job. But it's anything around the sugars. So there's different types of dumping, right away, right after eating, or it could happen a couple hours later. And the best thing in the world, of course, is to know what's in your food, like we said, and avoid the refined sugars. And of course, they can be in anything. And out in the free world of eating, especially in America, I mean, it's kind of like anything goes, in our food, takeout, and the things that they're enticing us to eat. You mentioned the sugary drinks. It won't take much to cause some of these problems. And the portions are huge. So I think that's when people get into problems they didn't expect. So high fat, high sugar foods are problematic. And if you do experience dumping syndrome, I understand it's best to just lie down and just wait, 30 minutes, and hopefully you're in a safe place to do that, but to really know what you're eating. And if you're not sure, ask your server, read the label, and go slow. The bariatric bite rather than whatever's served is probably best here. So what we try to do really is, even as I said before and after surgery, we try to eliminate the things that can always be a problem. So simple sugars, and that would include for some people the lactose that's in dairy foods, any concentrated sweets, high fat foods, and alcohol. And I can't think of any reason why we wouldn't have those to be out of range anyway. So especially after bariatric surgery, we want to keep those under control. And so in place of those things, then we want to have good lean protein. And I did put some ranges here for folks that may not know these numbers. So getting, 60 to 100 grams of lean protein a day would be a big help. That way, you're feeling like you ate something, you don't feel empty. Having, of course, foods with fiber in there would help. But it helps us to not to overdo the carbs, basically, and have that more balance of the food choices. So it's interesting that the carb control range is also 60 to 100 grams a lot of times. And just being able to know how to track that. So we do help patients to learn how to use the tools that we have now. I mean, we used to look all these numbers up and try to, estimate on food logs and such. But now we just basically speak into our smartphone, into an app, and it can tell us right away what we're planning to eat, or even help us to see what a total meal would be, either way, just ate it or we're thinking about eating it. And then anytime we separate the food from the fluids and allow time for the stomach to empty and continue hydrating, that's always a good thing. We could have a whole presentation on alcohol. I didn't go into it much, but we do have quite a problem in our country with alcohol. So I'll just say this. I didn't have a slide. I'll probably put one in next time. Alcohol in moderate amounts by itself can raise glucose. In excess amounts, it can have the opposite effect. And then, of course, we know that some alcohol is very high carbs all at the same time. So it's always a slippery slope with alcohol without bariatric surgery. But I just really caution my patients to be very careful with alcohol. If they've never had a relationship with alcohol before, and then all of a sudden they find themselves, everyone else is dining and they can't have that much food at one time. So what's the easiest thing to do is to have something to drink. And if it has alcohol, even the small amounts can be difficult. So and it can have an effect on the blood glucose. Yeah, so what should we do? Let's be positive. And so I don't think this is a coincidence that the year 2021 on our planet Earth is considered by the United Nations Food and Agriculture Organization the International Year of Vegetables and Fruit. And of course, every year should be the year of vegetables and fruit, because this is really the part of the food chain that we should be enjoying a lot of those foods. And the more that we have, usually the better we do. And we're talking about the plant foods, of course, that aren't the starchy ones. We're not talking potatoes and corn and peas. We're talking the ones that have more of the fibers and the leaves, eating more of the spinach, kale, cabbage, collards, lettuce, and the watery plants are really great, like the cucumbers and zucchini, squashes, all of those. And it's a long list. And a lot of times I find, I don't know if you find this, Dr. Peters, people aren't familiar with these foods, and they have to be introduced even as adults to have a new flavor, new experience with vegetables that weren't well prepared in the past, or they just weren't familiar culturally, or they were not available for whatever reason. So just knowing that there are lots of choices here, and including the ones that have proteins. So I always try to make this information available and include these in part of any good nutrition support. We do have stevia now too. We can talk about that for just a second. It is, of course, the natural sweetener from the mint family. It's a leaf. You can get a stevia plant yourself and use that to sweeten a drink without the calories, without the sugar. And I think a lot of people would appreciate that. So eating your plants, have a plant, enjoy these foods. Something, we always talk about what not to eat. And so these are things we can eat more of and enjoy them. So overall, just kind of sum up and the advice that we provide and the support we provide is to help target the 8 to be great. That's my last slide to just say, if we think long-term and holistically about managing weight management, diabetes, keeping it under control with or without surgery, these are the things that always help. And certainly the fluids. It's amazing how many people are underhydrated these days. I don't know what that's about, but it's so common. And then once that gets addressed, that helps, dilute the glucose and everything else on our body that runs on fluids. It's really gonna make a difference. And I love the way you always emphasize the physical activity. And of course, what is glucose? It's the fuel for our body. So we've got to move. And if people stop doing that, I love what you said about being strapped into our Zoom seat, here we go, another ride on the big, web. We're not doing much. And we do have to make an effort. And so this is going to help a lot. People do need to be rested though. So if they don't get enough sleep, they're sleep deprived. What do people do to stay awake with or without surgery? They're going to be looking for that quick thing. It's going to be maybe the caffeine, the sugary drink. And here we go again, back into, the problems that maybe triggered the high glucose problems all along. No stress these days. That doesn't affect our glucose, does it? Right? So a lot of times, people just are on overload. And then we have some good healthcare members now that help us with stress management, and getting that kind of help too will help with everything. We call our practice medical nutrition therapy. There's a reason for that. We do have to talk about the relationship that people have with food and how they get it, and having peace with making their choices and their body and how they feel about their decisions and coping. So, and if we need to get more help with that, of course, we refer to the other members of the healthcare team as well. So nourishing our mind, body, and soul makes a difference. And lastly here, to be great, we still need to continue to monitor glucose, have the A1C checked. You mentioned the malabsorptive things about the duodenal switch. And of course, what's being malabsorbed are the nutrients. So there's the pros and the cons to that procedure, as you know. And we would tell our patients that, yes, it's going to help with managing this problem, but having the nutrition and other nutrient deficiencies along with it, the risk goes up, in other words. So always getting the nutrient deficiency testing, and I know that CHRIAS does that with their patients over time, and then along with a good primary doctor, and the endocrinologist is going to check on these things. And always to help people to ask for help, listen to what they're saying, and make that referral, that connection. So with or without surgery, these are the things that help us target the 8 to be great. I hope that was helpful.
Well, thank you, Fran. And give me 1 second. I'm going to try to stop sharing here so that we all come back up on the screen. So usually at this portion, if we have anyone out there that has any questions, they can certainly put those in the question in the chat for us and let us know. Amy or Dr. Peters or Fran, are there any questions you have for each other? Any other comments that we want to make? We usually make this just an interactive aspect for the last several minutes of our presentation.
Fran touched on something that I didn't stress enough, which was one of the behavioral aspects of weight loss is good sleep hygiene. And another one that goes hand in hand with that is sleep apnea. Yes. I think the doctors and the patients don't understand that the treatment for sleep apnea often results in weight loss. Mm-hmm. So the pulmonologist is now a partner in weight loss management, by enforcing compliance and ensuring that they're getting good oxygen flow. Because the patient who's rested the next day is more active, and it does affect the metabolism overall. A patient who does not get sleep is lethargic, and their metabolism is telling them to slow down because they don't have the energy to get through the day. So good sleep hygiene, take care of your sleep apnea, and be treated for it. I know it's sometimes not comfortable, but patients who try it, they're alert.
Yeah. Most people I talk to after they've had the sleep apnea diagnosed, they're going to use the CPAP. There's an adjustment period, but then they're like, oh, why didn't I do this years ago?
Absolutely.
Big help.
I have a question for Dr. Peters. I often get questions from patients about their medicine, and they want to know, well, what's going to happen? Do I cut back on my insulin? What do I do with all my different meds as leading up into surgery? Can you talk about that a little bit?
Sure. I like to feel that I do medical management, but I got to be honest with you, when it comes to insulin and diabetic medications, the safest recommendation I've given is stop your insulin, the night before and the day of surgery, and you'll probably be able to stop insulin after surgery, but there will be oral medications you need. And then do I do liquid? Do I do crushed? And 10 years ago, everything used to be liquid or crushed, and now we're comfortable with pills because we found the patients just weren't taking their crushed meds. They were too nasty. So short answer is diabetic patient post-op, stop insulin, continue oral meds, but have a post-op appointment with me in 2 weeks and a post-op appointment with your primary care physician or your endocrinologist in 1 week. And that way, I don't mess it up.
Thank you. It is that they're hoping to go off their insulin. And I'm like, well, especially even in that 2 weeks before, it's something I'll talk to them about. Like, you're not going to need as much insulin when you're on the liquid. So you need to talk to your endocrinologist, your doctor, and make sure they know now you're having surgery. So there's a plan. I
neglected to recall that we put these folks on a very strict protein, low carb diet pre-op, and they will lose 15, 20 pounds at best case scenario. And their insulin requirements drop. And, I'll get phone calls from people, I'm dizzy. And I'm like, well, wait a minute, what about your medicine? And, I take 10 units. I'm like, no, you don't take 10 units anymore. You're curing yourself. And, that strikes them as odd, but they are. So you're right. I forgot the preoperative portion of med management, because that 2 week period, they get smaller. Call your family doctor. Stat.
Right.
Thank you.
We do tell them that when we talk to them. Usually we mention it.
I gloss over it, but it doesn't sink in. So much is going on. It's very hard for them to keep track.
Quite a process.
All right. Any other questions that we have? I don't see anything in our chat box right now. Any last minute thoughts or anything that anyone wants to share before we wrap up for the evening? All right. Amy, do you want to take us out with an update on when our next webinar is?
All right. Our next webinar is Wednesday. Of course, it's Wednesday, February 24th. So we have Dr. Valencia from United Medical Clinic talking about treatment of hypoglycemia. So how to treat a low blood sugar. And I will be talking about exercise with insulin. So type 1 diabetes with tailoring insulin for exercise. And then how do we manage activity with insulin? What extra behaviors do you need? So that is February 24th.
All right. Well, thank you. And again, just as a reminder for everyone, we do post these out on our YouTube channel. So it's United Medical LLC. And you will see there are a whole host of webinars out there. We have the bariatric series of webinars that happen with Dr. Peters and the other surgeons. And then we have all of our Wednesday webinars out there. We have United Medical Updates, where Kamal does weekly updates regarding COVID and a lot of other things going on in the medical community. They are out there in libraries, so you can find them easily. And we try to put titles out there that help lead you to the particular topic that you may be looking for. So again, thank you for joining us this evening, and we will see you back here in 2 weeks. Thank you all for joining us tonight.
Thank you.
Good
Thank
Thank you and good night.